السلام عليكم. أنا علياء قطبي, Professor of Pediatrics and Pediatric Cardiology in the Pediatric Department. I'm going to present you heart failure in infants and children. This is part 1. Our intended learning outcomes are that by the end of this session you will know the definition of heart failure, what do we mean by heart failure, recognize the pathophysiologic factors that lead to heart failure, understand the underlying causes or different age groups, recognize the presenting features, use the appropriate investigations that are needed to reach a diagnosis, and enumerate the treatment options. Heart failure is the clinical condition in which the heart fails to meet the circulatory and metabolic needs of the body. يعني القلب شغال بس it cannot satisfy the body as regards circulation and metabolism. Sometimes people think that the term heart failure equals congestive heart failure, but that is not true. هما مش نفس الحاجة. The term congestive heart failure doesn't apply to all cases because some patients have symptoms of exercise intolerance and fatigue without being congested. They don't have congested pulsating neck pain, they don't have liver congestion or edema, so they are not that congestive, so it is simply, we call them in heart failure. And this attracts our attention to a very important point, is that clinically you have to recognize the symptom of the patient when it is just starting. It is not difficult to diagnose the patient in a full-blown picture. يعني أنا العيان اللي بيجيني بيموت من الهارت فيلير أنا مش شاطرة قوي وأنا بشخصه. إنما أهم حاجة إن أنا ألقط العرض الأولاني اللي بيقول لي إن العيان بتاعي ده تعبان. فلازم من الشكوى البسيطة أنا أفكر فيها وأشوف فعلا by examination أو أشوف عنده سبب يكون مبتدي مع الهارت failure. So we have to understand that we don't have to wait for the full-blown picture of a disease. We diagnose by the first signs. Heart failure in general is the cardiac output which is equal to the heart rate times the stroke volume. What are the factors that affect the stroke volume? The preload, the amount of volume of blood going to the heart. The afterload, the amount of pressure that the heart is exerting. And the contractility, this is the intrinsic myocardial function. These three factors affect the stroke volume. Look at this figure. It tells us that in the preload, okay, the amount of blood, this is the volume of blood that comes to the ventricles. This is called the preload. الدم اللي بدخله جوه الفنتريكل هو الفوليوم ده قد ايه زاد قد ايه. انا اديت للعيان فلويد اوفرلود ده بقى بريلود. اوكي الجسم بيحوش فلويد يبقى ده بريلود. What about the afterload? Afterload is the pressure increased by the ventricle to circulate the blood. كل ما البريشر زاد الحمل على القلب الدنيا مقفولة في وشه يقوم هو يعمل مجهود زيادة عشان يتغلب على البريشر ده فيعمل ممكن ده يسبب heart failure. يعني stroke volume is affected زي اللي احنا ذكرناهم قبل كده preload زي large ASD أو fluid overload. Afterload زي aortic stenosis or hypertension. Contractility, like in cases of cardiomyopathy or myocarditis, the contractility is affected. What is the pathophysiological alterations that occur in heart failure? Regardless of the etiology, there is neurohormonal activation that occurs early when the ventricular dysfunction is present. What happens? There are increased plasma catecholamines اللي هو زي norepinephrine والحاجات دي بتعمل لي tachycardia and diaphoresis. Diaphoresis ده هو this profuse sweating because of disease. There is also activation of the renin-angiotensin system. This leads to peripheral vasoconstriction علشان يبعت الدم للأورجنز المهمة. الجلد مش مهم بس بقية الأورجنز مهمة. And this also leads to salt and water retention which leads to volume overload. So let us revise together. Look at this diagram. Early in the disease, there is congestive heart failure, there is sympathetic nervous system and renin-angiotensin aldosterone system stimulation. Okay, what does this lead to? It leads to increased myocardial contractility. There is myocardial contractility at first increasing with selective peripheral vasoconstriction, salt and fluid retention, and the blood pressure is maintained. So early in congestive heart failure or in heart failure, there is maintenance of the blood pressure. But as the heart failure continues, there are compensatory mechanisms that cause adverse effects. There is increase in the heart rate and in the contractility of the heart. This causes wall stress, so the patients become aware of his heartbeats. He's tachycardic, he's tachycardic، نفسه يبقى سريع، مش عارف ياخد نفسه من كتر ما القلب بسرعة، يبقى عنده palpitations، حاسس بقلبه عمال بيضرب. There is increase in the myocardial oxygen demand that exceeds the supply. فالبيشنت مش عارف يتحرك لأن هو محتاج أكسجين للميوكارديوم وهو it is not supplied, so he is unable to move. And in children, when increasing the heart rate, this is very difficult عشان تكونوا عارفين, because in children the heart rate is already on the tachycardic side. It is increased, so they cannot increase it anymore. So this causes heart failure to occur more rapidly than adults, and we have to be aware of that. That heart failure in infants is so rapid, he cannot stand a volume overload or a pressure overload. There is also alteration in the calcium homeostasis and the contractile proteins, leading to hypertrophy of the myocytes, and this leads to the full-blown pathophysiological changes that occur in heart failure. So broadly, we want to know what are the causes of heart failure. When you talk about heart failure, they get the impression that it is always the heart that is the cause. That sometimes there are cardiac causes and other times there are non-cardiac causes. And the cardiac causes are the arrhythmias, like the tachyarrhythmias or bradyarrhythmias, not simply tachycardia and bradycardia, tachyarrhythmias or bradyarrhythmias, structural heart diseases, and myocardial dysfunction, whether systolic or diastolic. The non-cardiac causes of congestive heart failure include the increase in the preload, as we said, like increased fluid intake. For instance, giving blood or fluids very rapidly instead of giving fluid intake for the 24 hours, you just give them very rapidly over a period of, say, 4 or 5 hours. This can lead to heart failure. Increase in the afterload, as in hypertension, decrease oxygen carrying capacity of the blood, like in anemia. Severe anemia can lead to heart failure. It's called anemic heart failure. Or increased demand that occurs in sepsis. We need more oxygen to the tissues, more blood to the tissues, and the heart cannot meet it, and thus heart failure can occur. These are the causes of heart failure by age group. In the preterm neonate, there is fluid overload. A patent ductus arteriosus or VSD can lead to heart failure, or a cor pulmonale like bronchopulmonary dysplasia. A full-term neonate can have an abnormality in the cardiac muscle, like in cardiomyopathy, and it is called at this age asphyxia because sometimes the most common hypoxemia or asphyxia during the neonatal period leads to cardiomyopathy, or viral myocarditis can also be the cause. Congenital abnormalities like the AV malformations, the vein of Galen malformation or hepatic malformation, abnormality, aneurysms can lead to heart failure with shunting. It looks like a shunt, but it is not in the heart, but it is in the brain. Left-sided lesions like coarctation of the aorta, obstruction by the aortic coarctation, hypoplastic left heart or critical aortic stenosis can lead to heart failure. Transposition of the great arteries or large mixing cardiac defects like the single ventricle or truncus arteriosus. Anemia and arrhythmias can lead to heart failure. At this age, supraventricular tachycardia and a complete heart block can be present. In infants and toddlers, left-right cardiac shunts like a large VSD can lead to heart failure. Hemangiomas act as an arteriovenous formation like shunts again. Anomalous left coronary. What's an anomalous left coronary? That's a left coronary that is arising from the pulmonary. Normally the coronaries arise from the aorta to get oxygenated blood to the myocardium. In this case, it arises from the pulmonary artery and gets deoxygenated blood, and thus the patient develops heart failure. Viral myocarditis and cardiomyopathy can be causes of heart failure at this age. Acute hypertension like in hemolytic uremic syndrome, supraventricular tachycardia, Kawasaki, and post-operative repair of congenital heart disease. As regards of etiology of heart failure in children and adolescents, rheumatic fever comes at the top of the list because it is common in areas endemic in rheumatic fever. Acute hypertension like glomerulonephritis, if you remember, in the toddlers we said it was hemolytic uremic syndrome, the most common cause. Here it is glomerulonephritis, and you're going to learn that in the renal lectures. Viral myocarditis, cardiomyopathy, arrhythmias, as we said, whether brady or tachyarrhythmias, thyrotoxicosis, cancer therapy can lead to heart failure, sickle cell anemia, infective endocarditis, cor pulmonale secondary to cystic fibrosis, chronic upper airway obstruction, and this is very important because it is frequently missed. For instance, imagine a child who cannot breathe normally due to large adenoids. If left untreated, when they cause complete obstruction, might lead to heart failure. Unrepaired or palliated congenital heart disease can lead to heart failure, hemochromatosis, and hemosiderosis. What are the presenting symptoms of such patients? In infants, it is very important that the mother comes and says there is poor feeding. Now, this is very important. Why? Because in the neonatal period, that is the most common complaint of mothers, that my baby is not feeding well. I cannot feed my baby. يعني البيبي أول لما بيتولد الأم مبتعرفش ترضعه كويس. طب ما هنعرف الشكوى دي إزاي؟ الطفل ده مش عارف ياخد نفسه. He is tachypnic. There is failure to thrive. He's not growing up. He's sweating profusely and with diaphoresis. And during feeding, this occurs during feeding. Why? Because the only effort the infant is doing is feeding. So that is why during feeding there is increased tachypnea and sweating. The infant might develop edema, but in the eyelids there are puffy eyelids. A neonate might die out of heart failure without developing edema of the lower limbs, so we don't look at edema of the lower limbs in the neonate. In children, they come with shortness of breath, and the mother again does not come and say shortness of breath. She says الولد ما بيلعبش زي بقية الولاد التانية، قاعد طول الوقت، ولما يلعب قلبه يدق بسرعة ويجي يقعد جنبي لأنه هو مبيبقاش قادر إن هو يكمل لعب. ممكن تقول بيبقى نفسه مقروش، ممكن تقول مش عارف ياخد نفسه كويس، إنها بعض الأحيان ما بتاخدش بالها. Easy fatigability, she says that he easy tires. There might be epigastric pain or even vomiting, and edema of the lower limbs. Sometimes the patient is lying down, the edema is not in the lower limbs, it is in the sacrum. Low cardiac output symptoms in these patients might include cold extremities, reaching mottled skin if severe, dizziness, altered consciousness, and up to syncope in severe cases. On examination, we have to lay stress on the pulse, the rate, the character, and the volume. Usually it is steady and rapid pulse. Look for the blood pressure, see how much is it. Look at the neck veins. Edema, as we said, varies in eyelids in the neonates, puffy eyelids, lower limb in ambulatory child, or sacrum if in a bedridden child. Abdominal examination has to be carried out. Look for the liver, enlarged tender liver of heart failure. Splenomegaly might be present in infective endocarditis, and look for ascites. Local examination to exclude for murmurs, for the etiology, tachycardia, and gallop rhythm. The chest examination for the pulmonales, wheezes, and pleural effusion. Examination of the heart murmurs help us to reach the diagnosis if I hear a murmur, so I know this is a cardiac cause. And a gallop rhythm makes me more sure that my patient is in heart failure. Examining the chest is an integral part of a cardiac patient in heart failure examination because the basis of the lung can show pulmonary edema and wheezing, or sometimes pleural effusion might be present as a complication. The signs include those of pulmonary venous congestion or systemic venous congestion or both. All patients will be having tachycardia, a gallop rhythm, or thready pulses. But in left-sided heart failure is predominant, then we will having tachypnea, orthopnea, wheezing, and pulmonary edema. If it is right-sided heart failure predominance, there is hepatomegaly, edema, with the side differs according to age and ambulance, and distended neck veins. But what is important to know that in infants and young children, heart failure is usually biventricular. It's usually all of these signs present together. You cannot say one sign is present and the other is not. The patient is having all of them. It is not like in the adults when you have pure right-sided heart failure symptoms or pure left-sided heart failure symptoms. The investigations include a laboratory workup in which we do the CBC, look for the serum electrolytes because electrolyte imbalance or low sodium can lead to intractable heart failure. Of course, the CBC, we look for it because of the anemia. Anemia can lead to heart failure if not treated or exaggerates and aggravates heart failure. Look for the blood gases, renal functions, and others according to the etiology because there are different causes of heart failure and you have to tailor the investigations to the symptoms of the patient. A 12-lead ECG may reveal evidence of structure or coronary artery disease or complete AV block or an arrhythmia. Sometimes we can use a Holter if we are suspecting an arrhythmia and no cause is found on the surface ECG. But the surface ECG will not tell you if the patient is in heart failure or not and will not put a final diagnosis which is the structural heart failure. Structural heart defect, for instance, it will tell you it's a left ventricle. It will not tell you what type of caused this, what structural defect caused this left ventricular hypertrophy. The chest X-ray shows cardiomegaly, pulmonary edema or venous congestion. On the chest X-ray, a cardiothoracic ratio of more than 60% in the newborn and more than 50% in older infants with congestive heart failure is the rule. So, how to make sure? The absence of cardiomegaly in a good inspiratory film with a diaphragm near the 10th rib posteriorly practically exclude congestive heart failure. So when a patient, I'm told that my patient he's severely distressed, he cannot the mother says he cannot respire well and he has been having difficulty breathing, and I do an X-ray and I find that the cardiothoracic ratio is normal, this practically excludes congestive heart failure. Look at this X-ray, there is cardiomegaly, increased cardiothoracic ratio. There is loss of the cardiac waste. Look at where the pulmonary artery is. Where is the pulmonary artery? Then the pulmonary artery is increased and increased bronchovascular markings. This another typical X-ray of a patient with severe congestive heart failure. There is cardiomegaly, alveolar edema, and haziness of the vascular margins. The echo in congestive heart failure is not diagnostic of congestive heart failure. It will just show me dilated chambers or the structural heart lesion. because an affected ejection fraction of the heart is a very late sign. It might not be present in all heart failure patients. Yet, echo is indicated in any child with congestive heart failure to identify potential cardiovascular causes, determine left ventricular function, and serial evaluation of the efficacy of therapy to see the size of the heart after we give the treatment. So, kindly be ready with your questions in the next face-to-face session about this part, and good luck. We're going to follow this by the treatment of heart failure.